maybe we can have some quick questions. I've two naive questions for you as a clinical cardiologist, not even an heart failure nurse. So when you ablate these patients with VT, so you create some scars yourself. How can you explain that this will not generate further on some arrhythmias?
So we try to do good at ablation. So that means that we have some endpoints. But that's why I very strongly believe that so creating a dense homogeneous scar is not arrhythmogenic. It has been proven several studies. Because the replacement fibrosis, if it's dense, it's replaced by dense scar, it's not creating any arrhythmias because there is no slow conduction going through that region. So that's why I find personally it's very important to create, really have good endpoints for the ablation and create homogeneous scars. But I do see sometimes when we are doing this, for example, with RF, we have a problem that there is a reversible zone around the ablation, and we create this inhomogeneous patchy scars. We do see sometimes proarrhythmia. And that's also the reason why, for example, we just had this discussion with Miguel, that if you see what happens after alcohol, that's a dead scar. We are also hoping that the new technology of PFA is also helping us in that it creates homogeneous scar, but it's indeed an important point to create homogeneous lesions.
Quick, oh, you want to go ahead?
Again, a question for Andrea. Sorry to harass you. So, but Frédéric has nicely shown that when you have an endocardial scar, you're quite happy to ablate this, and probably less happy to ablate patients with non-ischemic cardiomyopathies with epicardial scars. Do you address these patients to the surgeon, because we have the chance to have a rhythmologic surgeon?
Yeah, so we also had this discussion with Miguel. So Miguel is thinking that the problem is that we cannot effectively treat the arrhythmia substrate. I think in my eyes, in non-ischemic cardiomyopathy, there are exceptions like sarcoidosis. It's, it's indeed our recurrence rate is like 80%. I mean, but I think the problem is also sometimes the diffuse, as I said, the fibrosis, so the characteristic of the fibrosis. And when it's diffuse patchy, it's very difficult for us to organize it and also to localize it, to characterize it. And I also think you cannot burn everywhere. That's what I tell usually to my patient. And that's the reason why in the guidelines, the monomorphic and polymorphic arrhythmias are apart. Because if a patient has, arrhythmias coming from everywhere, in those cases, I think, so those patients, I do ganglion stellate blockade. I ask Frédéric to give his all pillars in maximum dose as he can, Tim to deload the left ventricle, decrease the filling pressures. In those patients who have everywhere irritability on the ventricle, we arrive during this procedure to the ventricle, they go immediately to VF, wherever you touch it, anywhere. So in these patients, it's very difficult to do anything with a focal therapy.
Carlo, do we have time for one more question or not? No, go ahead. Go ahead.
No, go for it.
No, just a broad comment on electrical storm. And we have a huge problem with the definition, because the definition is so broad, just 3 or more episodes of sustained ventricular arrhythmias. That includes patients with terminal heart failure that are just dying. That includes patients with normal hearts and, say, long QT. That includes patients with recent infarct and VF due to Purkinje activity in the peri-infarct zone. And that includes patients with monomorphic reentrant VT that could be very well ablated. So throwing at all of them the same approach is not going to work. We love the stellate ganglion blockade. I think it's a very quick buying time strategy to stabilize the patient. But it's no panacea for dying hearts, because you withdraw the sympathetic tone that may be important in sustaining them hemodynamically, and then sometimes you precipitate hemodynamic collapse. So that was just a broad.
No, it's a clear point, because the point is the electrical storm. It doesn't mean that it doesn't define the disease underlying. So you have to decide per disease.